Welcome back to Save Your Thyroid with Jennifer Holcomb, the podcast dedicated to bringing you the newest breakthroughs in thyroid health and patient-first advocacy. When a patient is told they need thyroid surgery, the fear often isn't just about the procedure itself. It's about the potential risks to the delicate structures surrounding the thyroid. Will I lose my voice? What will happen to my parathyroid glands? These are valid, critical questions, and to answer them, you need to speak with a specialist who is an expert, not just on the thyroid, but on the entire anatomy of the neck. Today, we're joined by an expert who is uniquely qualified to have this conversation. I'm thrilled to welcome Dr. Michael J. Wolfe. Dr. Wolfe is a board-certified otolaryngologist, or ENT, and a fellow of the American College of Surgeons, practicing at Proliant Surgeons in Washington State. His specialties include the surgical treatment of thyroid and parathyroid disorders, as well as the surgical management of head and neck cancer. What's especially relevant to our listeners is Dr. Wolfe's core philosophy, which he describes as compassionate, team-based approach that believes in educating patients on all options. Today, we're going to explore the surgeon's perspective on thyroid nodules, why protecting the voice is so critical, and how non-surgical options like RFA fit into the future of thyroid and neck care. Dr. Wolfe, welcome to the show.
Thank you so much. I've been looking forward to this.
Many patients, when they are first diagnosed with thyroid nodules, are referred to an ENT for these thyroid issues. And from your perspective, why is an otolaryngologist so deeply involved in thyroid care? What does your specialty bring to the table that is unique?
I think so. Otolaryngology is a surgical subspecialty that's sort of the way I describe it is everything above the collarbones except brains, eyes, and spines. And the thyroid is definitely one of those things that we see a lot. We have to team up a lot with primary care providers as well as endocrinologists. And we provide several services with the thyroid. We obviously do thyroid surgery for those people who have indications. We serve slightly a little bit, I would say, quasi-endocrinology, where we do work a little bit with the hormones and just sort of trying to make a plan for a thyroid care. This is one of those sort of it should be multi-specialty, sort of a multi-specialty care approach with different specialists sort of weighing in on what's the best for the patient.
Do you feel like that has kind of evolved over the last couple, last decade or two? Because just in my personal experience, I found that my experience with ENT locally was that it was very low focus on the thyroid function and more on the surgical aspects. So do you feel like in the last decade or so that kind of, like you were talking about endocrinology coming into what you're doing, has that evolved more, or is that just a personal philosophy?
It's, I would say it wasn't forced on me, but I was working in a multi-specialty group that had an endocrinologist I worked very close with, and I got a lot of knowledge from him. And then he retired, and my multi-specialty group did not hire another endocrinologist. So the way my group worked was I was next to primary care docs in different clinics all the time, and they'd always ask me. And it sort of fell into my lap a little bit. I always had, I could easily do consultations with other endocrinologists. I am not an endocrinologist, the first thing I tell people.
Right.
But I do realize the impact that thyroid function has on people, plus, hyper and hypothyroidism, also euthyroidism, how important that is. Then I will often start the therapy on my patients after surgery, or I've even started therapy for people who are hyperthyroid and need to come down in order to get surgery from uncontrolled Graves' disease. Because listen, in today's day and age, especially post-pandemic, we are very overworked, and to get into an endocrinologist can sometimes be 3 or 4 months. And if someone is hyperthyroid and tremulous and having palpitations, they need help now. And a lot of primary care docs are not comfortable with treating hyperparathyroid. I'm not, but I can start the process, make sure labs are going the way we want, and then pass that off to an endocrinologist. So I think that multidisciplinary approach is very important. I think an endocrinologist has a role, a surgeon has a role, but there should be some overlap with helping that patient.
Totally agree. And I think that's so crucial that you point to that point that patients are suffering and they need help now. Because, I've heard even 6 months to a year or even longer sometimes to get into an endocrinologist, which I've been told by some endocrinologists that that's actually, it's kind of a dying field. Like no one is becoming endocrinologists now, and which is so sad because we need them. And so I feel like, these patients, as you said, they're suffering now. They need help now. And so I think it's really great that you have kind of taken that on to start the process, get the ball rolling for them and get them some
I think
relief.
also when you said that it seems about past 1 to 2 decades where it's been a little bit more of that collaboration. I think the American Thyroid Association has had a lot to do with that. It
Really?
has really brought a lot of endocrinologists and radiation oncologists and pathologists, radiologists, surgeons together to
Mhm.
really form a collaborative group of people that are there to try to find the best care for that patient. There's every hospital should have a tumor board, and if you have a big enough hospital, you even have a thyroid tumor board. And I'm affiliated with a hospital here in Seattle that has a thyroid tumor board that meets every other week. And we have a patient. I have a 43-year-old woman with X found on ultrasound. My aspiration biopsy shows Y, and and we talk about those different details of the patient and find out what's the best treatment for them.
So important. Yes. Well,
Yes.
today we're going to explore the full spectrum of thyroid treatment, as you were saying, from traditional gold standard surgery to innovative and non surgical options like RFA, all from your vital ENT perspective. So, let's talk about when the patient first comes in and they've got symptoms of a thyroid nodule. They may not even realize that it's a thyroid nodule, but they have that lump in their throat feeling. A common complaint is that globus, as the term means,
Yeah.
and
Feeling of a lump in the throat.
they sometimes report a cough or trouble swallowing. That was me. I had coughing fits after meals, and I would always feel like I had that something caught in my throat. So when a patient comes to you with these symptoms, what is your diagnostic process?
So a lot of the time, I'd say most of the time, people come to me with known thyroid nodules, and we go through what the symptoms of the thyroid nodules could be. Typically, they're found by a primary care physician or another doctor who sees them. You hear the stories of people who are seen on TV and says, "Hey, what's that thing on your
Right?
neck?" Right? Or you go walk into the bank and the teller says, "Hey, you've got something there." And so
Mhm.
that there are those percentage of people. A lot of times they're found just you get a chest CT or neck CT or some other type of imaging, and it's found on the something's found on the thyroid, and they come in. So then I go through the process of what are those symptoms, and the mostly are non-symptoms. And the symptoms that then I talk about, have you noticed anything on your neck when you're putting on lotion, washing your neck, shaving? Do you have any problem swallowing or is food getting caught? And I specifically say, is there something going down and you have to swallow twice? Or do you need a sip of water
Yeah.
to pass it through that last little bit down here low in the neck? That's
Yeah.
fairly classic if it's the thyroid because it's pushing on the side of the throat. I
Hmm.
talk about pressure on the neck, specifically when people are lying back. Just the extra weight of an enlarged thyroid or a nodule pushing back is uncomfortable, and it
Hmm.
feels choky, or it doesn't feel like you're getting suffocated. It's just uncomfortable.
Right.
Or certain positions, putting on a turtleneck or a seat belt can also put pressure on the
Oh,
side of
yeah.
the neck. And so
Yeah.
those are the main things. Occasionally, you'll get somebody with pain or tenderness down low in the neck where the thyroid is. And the thyroid is down here, sort of between the collarbones and the voice box. If somebody says, I've got problems swallowing up here, then it sort of pushes me away from the thyroid. If somebody says it's down here in the chest, it's probably not the thyroid. Those are the types of symptoms that we're talking about if somebody has an enlarged thyroid that has an indication for treatment. Another indication for surgery or treatment, now that we're talking about RFA also, is a visible thyroid, something that's, a woman shouldn't typically have an Adam's apple like I do. And they'll say, I have an Adam's apple down here.
Hmm.
And or something to the side of the neck, to the side of the
Yeah.
real Adam's apple. So those are the things that we're looking for.
That was so I noticed it with myself. I actually didn't notice it initially. I never saw it. And then I went to the OBGYN's office for a checkup and he was talking to me, we were just having conversation and he's like, there's a lump in your throat. And I'm like, oh my gosh, you're right. I never noticed it. And then from that
Yeah.
point on, I couldn't not notice it. I would see it. And every time I took a picture, I would see it. I would delete all of my pictures because I didn't like the way it looked. And of course, it got bigger over the years. And then I started to feel it. I had the symptoms. And one of the funny stories I like to tell is how I actually, one of my hobbies is I do my own hair. I cut my own hair. I have since I was a teenager, actually.
Nice
And
job.
I Thank you. I reached a point when my nodule was at its largest that I could not breathe when I had my hands up and I was cutting my hair. And it
Wow,
was
you had a very
so
big nodule.
so awful. I would feel like someone was choking me, and it was misery. And then also, like you were talking about lying down, I actually could not lie down on my left side because the nodule was on my right side, and it was quite large. It was, my doctor said, between 65 and 75 mLs at the point that I had it treated. Before that, it was actually 45, and then I had an allergic reaction to some antibiotics that made it massively like explode over a very short period of time. So it wasn't like that for a long, long, long time. It was just in the last month or couple of months before treatment. But anyway, having that symptomatic, life altering, those sensations was just so terrible. And having that feeling of like someone is choking me all the time, it is no way to live. It is absolutely detrimental to quality of life. And so that's why I love talking about these solutions that can reduce these nodules.
Well, you talk about that. I should bring up that I've seen fairly small nodules cause symptoms. If it's sitting right
Yeah.
in the front, right of the isthmus, the area
Oh,
that
yeah.
your thyroid has two wings, we call the butterfly, and that connecting piece is the bridge of the isthmus. If you've got a nodule that's right on the isthmus draped over the trachea, it's easy to get those symptoms. They don't have to be very large, and they don't have to be very large to be symptomatic or visible.
Mhm.
On the flip side of that, I've seen absolutely massive thyroid nodules going down into the chest, going up to the up under the jaw, and they don't cause symptoms. And I've seen very small nodules that are easily feelable on an exam, and other huge ones that, like you said, you're 65 milliliters, sometimes they're 65 milliliters,
Yeah.
and you can't even feel them. They're soft. They grow
Yeah.
back, they grow down. So it's very, very variable on how people will present that way.
Oh, yeah. Everyone's so different with their anatomy. And for me, part of mine was going down below the collarbone even. But I've met other patients who had nodules the same size as mine that was all coming out of the
Yep.
top of their collarbone.
Yep.
And they looked like they had this massive, like a melon sticking out of their neck. And I asked them, I'm like, do you feel anything? They're like, no, I feel fine.
Yeah. So
It's
I think
crazy
also,
how different we all are.
right, if these things grow slowly, your body has a long time to adapt, and these
Right.
grow over years, if not decades. Especially your friend with the large,
Yeah.
the stereotypical goiter or enlarged
Right.
thyroid. They grow over a long period of time, and your body adapts, and you don't feel them. Those things that change quickly become symptomatic. You had a large thyroid nodule. You got a dose of antibiotics and had an idiosyncratic reaction, and it expanded it. And that fast growth, your body didn't have time to adjust, and
Right.
that's when you get those excessive symptoms.
Oh, and it was so bad. I wouldn't wish that on anybody. I'd like to take a moment to thank the sponsor of today's episode, RGS Healthcare. RGS Healthcare has been a leading medical imaging equipment distributor for more than a decade. RGS is known not only for recommending personalized medical equipment solutions, but also for offering continuous support to ensure success. One thing RGS is particularly known for is unparalleled physician training and on-site staff support. They are the only medical equipment supplier known for accompanying their doctors to exclusive, specialized thyroid RFA physician training on live patients proctored by leading world experts. If you'd like to learn more about RGS Healthcare, please visit their website, rgshealthcare.com. A heartfelt thank you goes out to RGS Healthcare for supporting this channel. Now, back to the podcast. So let's go back to the diagnostic process and talk about what's in your toolbox as far as diagnosis. Are you going to be doing laryngoscopy where you look at the vocal cords? Obviously you're going to be doing ultrasound. We have patients ask about imaging, what types of imaging, and then finally the biopsy. Walk us through those.
Excellent. So I'll say the typical patient would be asymptomatic, no symptoms, don't know anything's going on. They get an MRI or a CT scan or some other imaging of the neck, and it's caught, and they see a thyroid nodule. I'd say about half of those people come to me, they've already had an ultrasound ordered by their primary care provider. I have my own ultrasound in my clinic. It helps to see what the radiologist sees, and I'd say there's a significant portion, maybe 10%, that I don't agree with what the radiologist is seeing. And I look at what I see and I look at what they see. And sometimes I agree with theirs and sometimes I agree with mine. But the way I look at it is I'm the proceduralist and I'm going to decide what the patient needs.
Right.
With what I see on my eyes, because I think as a radiologist, they really don't have that clinical picture on what's going on with the patient. Right? They're seeing, we call it shadow pathology. They're just seeing grays and blacks and trying to make an educated guess on what's going on. And they're excellent. Radiologists are geniuses, and sometimes you just got to take a look at what they're doing. So somebody will come into me and I'll go over the full thing that we just talked about. What are your symptoms? Do you have a family history of thyroid problems? What has your thyroid function been? When the first time somebody has a nodule, they should get a TSH and a free T4 check to check the levels of function. TSH is the thyroid stimulating hormone. I don't know how much detail we should get into, but if the thyroid stimulating hormone is high, that means your thyroid is low. Your body says, hey, I need more thyroid hormone. I'm going to stimulate my thyroid, so makes TSH. And so if the TSH is high, that means there's low thyroid. If somebody is a low TSH, meaning high thyroid, then we have to look at what's causing that functional problem, and then they should get a radioactive iodine uptake scan looking at the function of the thyroid. And should not get a biopsy right away. Then if most people are going to be normal thyroid, what we call euthyroid, or low, and that's when, depending on the characteristics and size of the thyroid nodule on ultrasound. So a CT scan, MRI, they're good, but they don't call thyroid things very well. By far, the best imaging modality is an ultrasound. Depending on, I follow the American Thyroid Association guidelines. There's this TIRAD score that you'll get from radiology. They fairly closely correlate, but we're looking at size of nodules and different characteristics that may increase our suspicions for anything benign or malignant. And so anything that we think is mid to high risk, we will do a biopsy at 1 centimeter. You think 1 centimeter is about the width of your pinky nail, 1 centimeter. And that's pretty small. So we want to biopsy something like that. If it's low risk, we'll do something at 1.5. And there are some that are just super low risk that are highly likely to be benign. But once they reach 2 centimeters, we'd want to biopsy. So almost everything over 2 centimeters will get biopsied. If you see a pure cyst, you don't have to biopsy anything unless it's big and causing symptoms. And so then we do the biopsy. And the biopsy, there can be 4 biopsy results that the pathologist will talk about. There's actually 6 levels of the Bethesda scale. Again, lots of detail, but there's going to be benign, right? Go away, or see me in a year. And we like to do repeat imaging yearly if it's normal. If I've got a little bit of an inkling, really worried, I'll say come back in 6 months. If I say this is really, really, really low, I'll say come back in 2 years. But we want to follow up for several years to see if there's any growth pattern. If we do a biopsy, I put it into 4 groups. Benign, go away, come back in a year. If you're asymptomatic, we don't have to worry about anything else. They can say cancer. It's about 5%. And then we would recommend surgery. And we'll talk about what we would recommend in a little bit. Number 3 thing they could say, there's something in between. It looks weird on the microscope, but we can't say it's a cancer. We can't say it's not a cancer. And there's several levels of that actually increases the risk of it being malignant. We used to take all of those out. When I was a resident, that was one of the operating rooms.
Yeah.
And now we can send it for special testing that looks at the DNA and RNA of the specimen and can see what mutations there are, which will increase the risk or let us know if it's benign or not. So that then there's several different tests that we can send those to, and that might push us over into the possibility of doing surgery. And lastly, the 4th thing is non-diagnostic. And these are microscopic amounts of tissue we're taking out with a needle that's fitting in the barrel of a needle. And if it's non-diagnostic, I don't get enough stuff, the pathologist will look at it and say, Wolfe, not enough stuff, do it again. So we'll wait a couple of months, let the thyroid relax, and redo the biopsy. And then we make a decision with what to do next.
Wow. Yeah, it's a lot. And I mean, the patients feel the same way when they, when they're going through all this process of like, oh my goodness, what am I dealing with here? And, like you were talking about, sometimes it's this incidental finding and the patient is freaked out that they have something there that they didn't know was there before. To get from that point all the way through to the final diagnosis and the decision on a treatment path can sometimes take months. That's so frustrating for patients because, and I remember going through it myself. It was about 6 weeks, if not maybe 2 months or so, but that I was in that limbo of, I don't know what's going on. I don't know if I have cancer. I don't know. And I was so scared. And what I always tell patients is exactly what you said about only 5% of these are malignant. And the fact that that's not said from the rooftops, screamed from the rooftops,
Right.
is something
Oh,
that so much.
I scream it from the. I think one of my jobs is to help educate my patient.
Yes.
And I talk about the chance of this being a cancer because people are quite scared when they come in. The chances are only 5%, 3 to 5%. And then most of those are called papillary thyroid carcinoma. 85% of thyroid cancer is called papillary. Very slow growing, very indolent. These are the ones that can be in the body for years and cause no problems.
Right.
They do readily spread to the lymph nodes. They'll spread very quickly to the lymph nodes. But even with lymph nodes spread, the prognosis is still quite good. And there's other cancers is once it's in the lymph nodes, it's very difficult to treat. These are not that way. Unless you've got lots and lots of lymph nodes, that shows us how aggressive it is. But you got a couple, few lymph nodes in there. It does not change the prognosis. You cannot get, cancer staged 1 through 4. You can't even get above a stage 2 below 45 years old. So you can't even get above stage 2. If it's metastatic to the lung, you're a stage 2.
Wow.
It's like it's unfathomable. It's very, very low. Now, I have seen papillary cancer be very dangerous. I've seen it be terminal. That's not the norm. They can dedifferentiate, meaning the cells can be normal papillary thyroid cancer and then change into something more dangerous. Those are the things that we talk about. I tell people, even when I do a biopsy and I say, unfortunately, this shows that you have a papillary thyroid carcinoma, the first words out of my mouth are, these are very slow growing, very indolent, and we have an excellent prognosis of making this go. We have between 90 and 95% cure rate on that.
Right.
The second most common type of thyroid cancer is called follicular thyroid carcinoma. These are cancers that are from the thyroid cells, so follicular and papillary are from the thyroid cells themselves. And that's probably most of the rest of the 15%. Are follicular. They're a little bit more aggressive. Cure rates are 85 to 90% for the lower grades. And you can go from these two, the curable, to an anaplastic, which is very, they're very infrequent. I wouldn't say rare, but infrequent. And they are probably one of the most malignant cancers and are very dangerous, very fast. And people will say, well, how do you know it's not anaplastic? Because we're sitting here having a conversation, and these are things that will develop in weeks, not years to months. It is very fast growing. So it's pretty apparent fairly early on if it's an anaplastic.
I had not ever heard that before about how rapidly anaplastic would progress. So that's very different from papillary, which, as we were talking about off camera before we even started, that papillary cancers can even be found on autopsies of people who've died from other causes and had no idea they even had them because they're so incredibly slow growing.
Yep. And then once someone's treated, there are unfortunate cases that people will have distant metastases. So we talk about metastases. There are metastases to the lymph nodes, and there's distant metastases, and those are all measured in the staging system. And distant metastases, you have a lump in your lung that's found to be papillary cancer. People can live decades.
Wow.
With that. So it can be, again, slow growing and not cause a problem for a long time.
That's amazing.
There's a huge spectrum of growth patterns, but papillary are one that people can go a long time.
So this is a topic, this topic we've been on for the last few minutes is something I try to touch on in almost every episode of this podcast, because I know there's people coming back, but there's also lots of new people coming who don't know this information. And my goal here is to dispel a lot of that fear and anxiety that comes with that initial discovery of the thyroid nodule. So I'm so glad we covered all of this. For those of you watching, this was not exactly in our notes. We were kind of going off script here, but this is important information. I want to share it with you guys. Hey, just a quick break to share something I'm really excited about. My brand new website, saveyourthyroidwithjen.com. You can head there to subscribe to my mailing list and stay in the loop about new podcast episodes, videos, and updates in the world of thyroid nodule care. And I'm now offering something new, one-on-one patient navigation services. If you're feeling overwhelmed or unsure about your treatment options, I'm here to help. As a patient who's been through this myself and spent years learning from some of the world's leading experts in thyroid nodule treatment, I can help you make sense of your choices and feel more confident in your next steps. You can learn more about patient navigation and everything else I'm working on at saveyourthyroidwithjen.com. Now back to the conversation. So we're going to talk a little bit, before we get into RFA, we're going to talk a little bit about surgery, because that's your bread and butter as an ENT surgeon. And I want to hear your perspective. The gold standard for thyroid nodules and thyroid cancers for 100 years now has been surgery. And so even in the last few decades, we've been treating benign nodules that were symptomatic with a partial or a total thyroidectomy. And now we're shifting away from that. We're seeing less and less of those benign nodules removed, thankfully. And then now even more with the development of these non-surgical procedures. So walk us through the procedure of removal of half or all of the thyroid gland, and what are the risks of that regards to the voice and the parathyroids?
Excellent. So I'll talk about the indications for thyroid surgery, the ones that I tell. There's lots of indications, but the main indications are if I do a biopsy and it shows cancer. Some of those tumors that we can't tell the difference, if they have a higher risk, we'll take them out. Sometimes you can't get definitive diagnosis until the pathologist can look at the entire nodule. So cancers, some we can't tell the difference. Symptoms, and we talked about those symptoms already. Those symptoms are pressure on the neck with certain positions, pain, and problem swallowing. So not very many. A lump protruding out of the neck is an indication for surgery. And then lastly, the most one of the more common ones is that, or one in that common list, is hyperthyroidism that's not responding to medicine, or a person can't tolerate the medicine. We talk about dirty medicines. Dirty medicines can do a great job, but if they have too many side effects and you can't tolerate them, they're not very helpful. And so methimazole is one that helps the overwhelming majority of people. They do great. And probably got 10%. I don't know, I'm going to throw a number out, 10% that just don't seem to be able to tolerate it. It makes them ill. It can change other labs, and then they can't, then it won't. Surgery is an option. Also, people with Graves' disease will be on methimazole for a year or two and then try to get tapered down and weaned off. If they recur, then you can restart the methimazole. If they recur again, then surgery may be an option. Another treatment for Graves' disease is radioactive iodine therapy, which can work well. It's probably done, of the people who don't tolerate medicine, it's done probably about 50% of the time in the United States still, and surgery is the other 50%. If you have the Graves' ophthalmopathy or the Graves' eye disease that causes the buggy eyes, then you should not get radioactive iodine. So those are the main indications for surgery. Once we decide on surgery, we decide what the surgery is. If it's a benign uninodular nodule on one side, we talk about multinodules. Uninodular would be one nodule on one side. If it's only one side, then we can take out one half of the thyroid. Sometimes people have lots of nodules in both sides, even if they're benign. If they're symptomatic, we'll take out both sides. I haven't seen it in a long time, but sometimes somebody will come to me and say, I had a really big mass on this side and they took it out 20 years ago, and now this one's really big, and so it might need the other side out. So there's the three types of thyroid surgery. Is the hemithyroidectomy, you only take out half the thyroid. There is a total thyroidectomy where you take out both sides. There's completion thyroidectomy, where you take out one side and then later on a different day you take out the other side, which has the same risks as a total thyroidectomy. We talk about subtotals and near totals. Those are really kind of old school surgeries. We try not to leave any thyroid behind in case there's any other issues in the future. If you've got a little tiny bit of thyroid left in the future, it's very, very difficult to get that back out again. So those are the indications that I use for surgery. The risks of surgery, bleeding and infection, goes along with any surgery. Anytime I break the skin, anytime I poke somebody with a needle, I say bleeding and infection. Those are extremely rare. The risk of bleeding at the time of surgery, I've never had to give a transfusion. Sometimes they can bleed a lot. Sometimes they don't bleed at all. The risk of bleeding that we worry about as surgeons is the bleeding after surgery. You get it closed up, and if there's bleeding in the neck, you get what's called a hematoma, which can be dangerous. They can pressure on the neck, put pressure on the voice box, put pressure on the vocal nerves, and cause problems breathing, and that should be urgently taken care of. That's a hematoma. Risk of a low thyroid. If you take out the whole thyroid gland, you have a 100% chance of hypothyroidism, and you're gonna need thyroid hormone. If you take out half, I like to tell people it depends on where your TSH is. If your TSH shows that you're kind of almost low, then your risk of hypothyroidism is higher than somebody who has a lower TSH and has higher baseline thyroid function. But basically, I tell people you have about a 20 to 25% chance of hypothyroidism. I used to say 30. I think over the years, I don't know if it's my technique or not, but it seems that that's gone down a little bit. It does happen, and a lot of times you get your 1 month, you get your TSH 1 month after surgery, and it might be just a little bit high, and I think it's just the other side is shocked, it's sort of angry at us, and at 6 months you're fine again. So if you're asymptomatic and mildly hypothyroid, I'd probably not want to treat it. So that's hypothyroidism. There's a risk of further hypothyroidism later on in life. If you only have half a thyroid, you've got less reserve. Then
the voice and the parathyroids. Do you want to talk about that?
Next is the voice. So damage to the nerve to the voice box. The nerve to the voice box comes out of the chest, runs up next to the windpipe, behind the thyroid, behind the parathyroids, and goes right into the voice box. And we see that on every surgery. We want to see it. If we see it, we can protect it and stay away from it. The risk of a paralysis of the voice box is less than 1%, and a paralysis would cause total loss of voice. Taking a breath in the middle of your sentences because you're losing too much air. The voice box isn't working very well. About half of those will come back and half won't. There are things we can do procedurally to help the good vocal cord work better against the bad vocal cord. Then there's, I say it's about 15%. It may be 10 to 20% where people will wake up and they'll be a little bit gravelly above and beyond the swelling caused by the breathing tube. A little bit gravelly. Maybe they'll have some vocal fatigue where they're talking on a phone and they're talking as much as I am right now, and they'll start to feel like they're running a marathon with their voice box and that vocal fatigue. And that's just where the nerve is bothered and maybe a little traumatized, a little angry at us, and that takes a few weeks to get better and better. And a lot of people notice nothing. If you are a singer, lots of singers, in fact, most singers will notice a change in their voice and sometimes change in their pitch range that can last weeks to months. So that's very common. So it's very spicy when we're having singer in needing surgery.
Let me put this one little side note in here for when we get to the RFA discussion. That's one of the things we see commonly from patients who are singers or actors, and they've been referred for surgery, and they're very interested in RFA as an alternative to that because they're just so scared of losing their voice.
Yeah. It is probably the one thing that I worry about the most in surgery.
I'm sure.
It's the most immediate and I think it has the most impact on someone's life and well-being because your voice is you, right? It's part of your identity.
Yeah,
absolutely. Then we talk about the parathyroids. There's 4 glands, superior and inferior on both sides. They're very, very small. We say grain of rice are a little bit bigger than that. I call them lentils. They're like little lentils. There's 4 of them. You only really need 1, but you have 4. Thank goodness. You have a little redundancy. And you have about a 2% chance of prolonged low calcium. So the parathyroid glands control your calcium level at a very tight. If they notice that your calcium is going a little bit low, then they'll bump up the parathyroid hormone, and that helps you retain your calcium into your blood. And then opposite, if your calcium is high, then the PTH will go low. So they get shocked during surgery. You can only get it on a total thyroidectomy or a completion. If you leave 2 alone, you're going to be fine. If you're bothering only 2, then you're not going to have to worry about it. But so you do a total thyroidectomy or a completion thyroidectomy, if they are damaged or shocked or removed or destroyed, you can get what's called a profound hypocalcemia, low calcium due to low PTH. And it's about 2% of people will have this prolonged serious low calcium. 2% is a lot, if you ask me. And I'm talking about lots of high doses of calcium during the day, and some special medicine called calcitriol, which is a strong vitamin D analog that helps you absorb the calcium better. And the symptoms of low calcium are numbness and tingling in the lips and fingertips. Not dangerous, kind of tells you there's something wrong. Cramping is dangerous. Once you start cramping, that can cause heart arrhythmias, and it can cause your voice box to close. We call a laryngospasm, and then you can't breathe, and it can be dangerous. That's extremely rare. So almost everybody who gets a total thyroidectomy will have an asymptomatic, unclinical, lower calcium. Almost everybody will be sent home on some calcium just to prevent that drop. And occasionally people are brought into, if the calcium is going too low, they're brought into the hospital for just calcium maintenance.
Those are all important things to discuss. And as you said, the risks of those happening are very, very small percentages.
Yep.
And, which is good. We want to make sure that that is, as low as possible when we're going to
Right.
choose to have surgery. However, as we kind of now go into the topic of radiofrequency, are those risks even lower with radiofrequency?
They're very much lower. That's the one thing that those are the biggest advantages of radiofrequency ablation.
Mm-hmm.
It's minimally invasive. It's a day procedure. You go home, you should have almost no restrictions the day that the procedure is done. The risk of hypoparathyroidism and low calcium is, I hate to say zero, but it's kind of close to zero. If you're not mucking around with the area below, underneath the thyroid, you're not going to be messing with the parathyroids.
Yeah.
So I would be that's almost a non-starter. And then the risk of low thyroid hormone, also extremely low. Whenever you are reducing the volume of thyroid tissue, there's always that risk. The whole idea is you don't know how much thyroid hormone your nodules are making. Typically, if you still have viable, normal thyroid tissue around your nodules. So if you're only ablating a nodule, you're not touching any of that normal tissue, your risk of hypothyroidism is extremely low. And the biggest risk, the thing that I worry about the most for serious side effects is the nerve still. And you can transiently heat up the nerve, and it can get bothered. It depends on anatomy, where the nodule is, where it extends, how close is it to the nerve. We do have some safety protocols in place to help try to preserve nerve function. If you've got a nodule and the nerve is right next to it, we're not going to ablate next to that. It will leave that area of the nodule alone. The risk of hematoma, you're not. Anytime you poke a needle into the gland, you have a chance. When I do a fine needle aspiration biopsy, which is a much smaller needle than the RFA probe, I talk about hematoma, which I've seen once in 20 years, where the thyroid bled and the person needed to get half the thyroid out. And it doesn't mean that person did a bad job. It just is going to happen. It's one of those things that can happen. The risk of hematoma is real with this. I've not seen it, but we always worry about it. Another risk that we have is sometimes it can be quite pain. It's uncomfortable afterwards, but sometimes if some of that tissue leaks out of the thyroid, that damaged tissue can leak out of the thyroid, that can cause some pretty significant discomfort. So we treat with steroids and pain medications and ice packs.
Are you referring to nodule rupture with that?
Yeah.
And that is super rare. Like, I think that's like less than 1% of cases, or even less. Yeah, I think it's less than 1% of cases. We have seen it happen with patients in our community, and I won't speak for them, but my understanding of their situations is that they tend to be happy once the whole rupture process is over, because they get a dramatic reduction in their nodule after they go through that rupture process, which is not fun. And I really feel for those patients, because it does look unpleasant, but we're actually supposed to do an episode on that. But it's not something that the vast majority of patients should be concerned about, because like we've been saying, all of these are extremely low percentages of risk, and that one is particularly low risk.
Right. So it's one of the dramatic ones, right? It's quite dramatic. Yeah. I've not seen it. I've not, but I, you read about it and you know what to do about it, and you warn the patients so they know that everything's going okay, but they do need to be aware of it. Any risk. That's why we call it informed consent, right? You have to be informed before you can give us consent, and that's the law.
Totally agree. Well, speaking of being informed, how did you get informed on RFA? How did you get started on this whole journey of offering this?
That's an excellent question. Actually, a patient better informed than I brought it up to me. She had a very large thyroid nodule. And she said, well, what about, and she talked about laser ablation. There's three modalities: laser ablation, microwave ablation, and radiofrequency ablation. And radiofrequency, they all are similar. There are really no good advantages from one over the other. I think RFA is easier and a little bit more, is probably the most popular, the most common that you're going to see. I do RFA. And the woman said, hey, what about this ablation with a needle? And we're like, what are you talking about? I've never heard of that. And that's kind of a wacky thing. She helped me. I said, I want to know more about it. And I didn't have any resources. I didn't know who I could send her to. And she did reach back out to me and gave me some resources. And it was something that was being looked at more in Europe and Asia. As always, everything goes in Europe and Asia before the United States. The FDA tries to protect us from anything. And I think the other countries have a little bit less strenuous regulations. And so, especially in Asia, the culture doesn't like scars. So they try to avoid any type of scar on the front of the neck. And the data was good. And it took a long time to get to the United States. And was reading things about it. I've had people come talk to me and ask me about it. And it wasn't until several years later, and I'd probably say, I would say 5 years in the Seattle area with a very, very strong medical community. The University of Washington started to do it, and the endocrinology started to do it. I talked to another endocrinologist down in another neighboring town, and she called me directly and said she was doing it, and I would send people to those places. Very few people really are doing it. And I still think that access to RFA is very slow to grow in, actually like in Seattle area, very strong medical community. And it's just a technology that hasn't been grasped yet. And I think it's because we have very strong surgical community and surgeons like to do surgery. And so I thought about it a few times. One of my very, very good friends who does a lot of thyroid surgery at the hospital that I go to, they almost took it up, but they said, we're just too busy to do it. 3 years ago, I changed practices, and it gave me the opportunity to look into doing the RFA. And that's when I contacted some people about it. I took the class, learned RFA, and then now have the equipment in my clinic. So that's how it went on. And the reason why I think it's important is because you need to give people all options. I don't need to do it to give them the option, but I need to give them that option, tell them that option's available, and then have that resource to send it to give people. So whether it was in these other areas, or again, I didn't see the access to getting RFA in those two places to be very good. So I decided to start that as part of my practice.
Well, I just want to say kudos to you for letting that seed be planted by your patient.
Yeah.
That's phenomenal. I actually tried to do that with my own local ENT, and he was not receptive at all. I also believe he was probably towards the end of his career and close to retirement, so he probably wasn't wondering what can I add to my plate at this point in my career.
Right.
But I think it's so critically important that, like you said, patients know all their options. And patients today are very proactive and also advocating for themselves for things that they feel are maybe better suited to their personal lives and situations. So let's talk about when a patient comes to you and you're having this discussion about RFA versus surgery. When you're having that conversation, how do you help them make that choice?
So the person pretty much already has in their head what they want. Most people who get the RFA come into my office and say, I've got a thyroid nodule, tell me about RFA. And very few people actually make, I shouldn't say very few, but a smaller percentage than you think need to get talked into one way or talked one way or the other. The gold standard is still surgery and probably always be surgery. We should talk about the specific indications for RFA. The accepted indications are people with a symptomatic nodule or somebody with a visible nodule. So if they feel the pressure, if they have the problem swallowing, and I don't know if we talked about this problem swallowing, I think people will notice that they might not even really notice it. It's so insidious as it gets worse and worse. You don't even know that's a problem. The food getting caught and you're swallowing twice, or do you need a sip of water to make it go down? Oh yeah, it's or not. Well, look at your thyroid, and it's probably the thyroid. In fact, if you have a problem swallowing with a large thyroid nodule, the chance of fixing that problem swallowing by treating the nodule is over 90%, 90 to 95%. We can fix that problem swallowing. So if there's a lump on the neck or your problem swallowing, that's when RFA works well. The other one that I have not done yet, because it's not as common as you think it is the autonomous nodule. One nodule, a little tumor, not a cancer, makes too much hormone and doesn't respond to signals to shut down. And it's the other most common cause of hyperthyroidism. We can ablate that thyroid nodule non-surgically, no radioactive iodine, no medicine. We can take care of that in one sitting. And there are now people touching on small, stable papillary cancers. And we are starting to talk about parathyroid adenomas. Those parathyroids can cause their own problems with making too much hormone, causing too much calcium in the blood. We're starting to look at ablating parathyroid adenomas depending on anatomy. They also talk about maybe cancerous metastases that are not surgically amenable. We can radioablate those. Those are so the main ones: symptoms, visible, and then there's some talk about doing other things. I'm going to digress 2 seconds. Another risk of doing the rate of RFA is that it might not work as well as we want it to, and you might have to do it a second time. And that's obviously the bigger and the more nodules, that the more common that is. And we can also only do one side at a time. We can do isthmus and one side, but you can't do two sides at the same time because there might be swelling, and that would be uncomfortable.
Absolutely.
And press on the windpipe. Yeah. Sorry, I had to digress. I forgot about that.
No, those are important points to make. And I'm glad you mentioned that about both sides, because we do get that question a lot from patients that have multiple nodules. And, if you only have one dominant nodule and then the rest of them are smaller, you don't even necessarily have to treat those smaller ones, just the dominant one that's
Correct.
really causing.
You want just the big one, right? And that's what I tell people. Listen, you got a big one here and you got a big one here. I can't do them both.
Right.
We're going to do this biggest one, whichever one I think is going to be causing the most problems. And you may not need to do the other one ever.
Right.
But you can wait a while and find out how you're doing and then do that one later. That's the whole idea about RFA is minimalism. It's about the symptoms. Get rid of the symptoms. One of the first persons I did, huge singer, huge bilateral, and a large isthmus. And I just saw them the other day, and they said they're extremely happy. And this big mass in the front of the neck is gone. And I look at the ultrasound of the thyroid and I'm like, oh my goodness, this is huge still. But we took care of the symptomatic nodules. And so we are... Yeah. They did want to do the other side, so we're getting them planned to get the other side done. So
that's phenomenal. I'm glad you shared that, because those nodules, even if they're really large, if they just shrink a little bit, sometimes that's all it takes just to give the patient improvement in their quality of life. And so that's just wonderful to hear. I'm really excited for that patient. And, the voice is so important for those people who professionally sing or act. So you talked about there's not a huge number of providers in your area and who are offering this. And I am excited as we look back 6 years ago when this came on the scene, that we are seeing more and more adoption of non-surgical techniques, but it is still not widely available. Like, there's one doctor in my city who offers it. And, 6 years ago when I had my procedure, I actually went from Alabama to Virginia to have a treatment because there was nobody any closer that I was aware of. I think there might have been one, but I'm not sure when he actually started. So many patients today are looking for this procedure, and they will travel in a lot of cases to find the right doctor for them. So what's your advice for those patients who've been told maybe by a local physician that doesn't know about non-surgical options, that they need surgery, but they're really interested in exploring RFA? Would you encourage them to maybe travel or do telehealth with the physician who's offering this to find out about their options before they make that decision?
Absolutely. I think with thyroid, you have time.
Right.
It's very subjective about the quality of life that the nodules are causing, quality of life issues that may or may not be causing. But you have to, even if it were a cancer, not that we're going to radioablate a cancer yet, but you have time to really sit down and get other opinions. And I almost hate to say look on the internet nowadays, because there's so much weird stuff going on the internet. But trying to find those resources, the American Thyroid Association is one of my favorites. They obviously accept it, and it's not part of their protocols yet. They're about to come out with a new set of ATA guidelines, American Thyroid Association thyroid nodule guidelines, where we're hoping they're going to have a little bit more say on the RFA. But trying to find those, I don't work at a university or a major, I'm in private practice, so it's hard to find good access to those. If you do, I always say, look at your local university hospitals, because they're going to have people. Hopefully, it's likely not giving you an otolaryngologist. That's what I think. I'm a little bit unique, as I can give both. I can talk about surgery because I do surgery. I can talk about RFA, and I can give you the pluses and minuses of both.
Absolutely.
But they're mostly going to be endocrinologists that are doing it because they want to have that they want to do the same thing. They want to be medicine, but they also precisely want to see what they can do about thyroids. So talk to your endocrinologists if you are. If you're worried about the lack of access from your surgeons. I do have some contact with naturopaths who don't want their patients are usually very averse to any type of surgical management or overly invasive things. And if they're not responding to the therapies that their naturopaths give them, then they send. I don't think they're quite an open resource yet, but I think they're going to be more in tune to who's going to be able to give that access. So something to think about.
Yeah.
Yeah, it's very difficult.
Complementary, really, when you think about it, for the patient that's trying to do a more natural approach to their health, but they've got this thing that's really impeding their quality of life. This is a great option for them because you're still going to have your thyroid gland intact and your function is going to be there.
Which I think is kind of one of the strong pushes from the naturopathic community.
What would your key takeaway be for a patient who is feeling just absolutely overwhelmed by this diagnosis? How would you advise them moving forward on this journey?
Yeah, that's I like the word overwhelmed. There's some people who are very cavalier about getting surgery. Those people bother me. And there's some people who are too overwhelmed and too anxious. And I have to try to wrangle these people in. Like, no, we don't need to take yours out, but I don't want a lump of my thyroid. But you don't even have an indication. We don't need to do that on you. Then you have another person who really, really needs surgery and is very reticent and are trying to back up. And sort of some of my job is hand-holding. And people always ask, well, why are you 25 minutes behind in clinic? Well, I'm not going to rush you like I didn't rush the person before you because they need my help. So I say just an open mind and get the information. I'm a huge proponent of second opinions or third opinions, realizing that if you keep getting more and more doctors just trying to find the opinion that you want, you're probably not doing yourself a favor. If you're starting getting the second, third opinion, they're saying the same thing. So maybe that's close to the right thing to do.
Absolutely.
And being realistic as to what needs to be done. And I think we had this conversation before we started recording, is that I always feel that I'm there to be an advocate for my patient, and I might recommend surgical management, maybe for cancer. And if they say, I really don't want to go that route, I will recommend this is what we do, and that's the gold standard, and that's going to help you. But if this is the decision you're making, I will support you, and I will do what you need, whatever I can do to help. And we'll see you every 2 or 3 months. We'll make sure it's not getting bigger. We'll do everything we can, but try to walk them down the road about what still needs to be done. And everybody, if you give them time, will be able to make a decision. And I think it's very important to give them the information. A lot of doctors will speak. Doctors speak.
Yeah.
I do doctor speak and then explain it, and then do doctor speak and then explain it. I have a lot to say. I'm behind in clinic. I will talk fast and slow your doctor down. If you need to say, I didn't get that, please repeat it.
Yeah.
Then if somebody is offended by that, then there's your opinion. Maybe you should find somebody else.
Right.
Maybe you just don't like the guy, but you know they're a good surgeon. It's a full thing. You need a good surgeon. The good surgeon's been shown over and over and over and over again as the people who do it the most.
Right.
So they say, what's enough? Typically, they'll say 20 a year, 20 thyroids a year is enough. There are people who are doing, way more than that. You want to seek out the one who's doing
volume. Them. Yes. I think that you made so many wonderful points there. You want to be in a relationship with a physician that you feel like you're on the same team, where you're working,
right.
Where your physician's advocating for you as well as you advocating for yourself as a patient. So vitally important. You don't want to be, even if it's a good surgeon, an excellent surgeon, if you feel like you're at odds with one another, it's probably not going to work out as well as it could if you had a better rapport with that doctor. And so I think that's so vitally important. And I thank you for all of your amazing points that you've made today. How can patients learn more about you and find you if they want to come work with you?
I have my own website. It's seattlethyroid.com. I have a lot of information. It has other things that I do on there, not just thyroid. I'm trained in cancer surgery. I've done a fellowship. I was in academic medicine for several years, and then fulfilled my promise to my wife to come to the Pacific Northwest and took a general otolaryngology job. I still do lumps and bumps, the big, huge cancers. I send to people who do that more often now, but I do a lot of thyroid, a lot of parotid. I do the Inspire hypoglossal nerve stimulator for obstructive sleep apnea. Those are the things that keep me the busiest, the thyroid and that. So you can find me thyroid at seattlethyroid.com. I'm also at ProLiant Surgeons. The name of my group is Puget Sound ENT. I'm under the umbrella of ProLiant Surgeons. Those are the easiest. Probably, I also on my website have a button you can click to ask me a question, and it comes right directly to my email, and I
that's wonderful.
answer everyone's question. Well, I answer if you're telling me you can fix my website so I get better visualization. I'm not going to answer you.
I get those a lot too.
I try to answer everybody's questions, and forgive me if it takes me a few weeks, but usually it's within 3 or 4 days I'll give you an answer.
And I want to just add here, because we have our website, saveyourthyroid.org. If you are looking for a doctor, you can actually find, and we need to make sure you're on the list, Dr. Wolfe, because that's our resource that we point patients to when they are looking for a physician in their area or somewhere where they would be willing to travel for treatment. So saveyourthyroid.org is that resource. Dr. Wolfe, this has been such a great conversation. I would love to have you back, and just thank you so much for all of your time and expertise today.
As you can see, I have a lot to say.
Hey, that's a good thing. That's a good thing. That wraps up today's episode. If you found this valuable, please like, subscribe, and share it with someone who might benefit. You can find links to everything we discussed in the show notes below. Find a physician, discover treatment options, and join our patient community at saveyourthyroid.org. To stay up to date on new episodes, resources, and expert insights, be sure to subscribe to my mailing list at saveyourthyroidwithjen.com. It's the best way to stay connected and informed. There you can also find all podcast episodes and book a 1-hour patient navigation consult for personalized guidance on your next steps. As always, please remember this podcast is for informational purposes only and is not a substitute for professional medical advice. No endorsement is given or implied for any specific product, treatment, or physician mentioned. As always, consult with a qualified healthcare professional for your individual needs. Thanks for listening, and I'll see you next time.